All right, we're going to continue with our discussion of the skin. Last time we talked about the two layers of the skin, which are the epidermis and the dermis. Recall that the epidermis is made up of primarily stratified squamous epithelial cells, except for the bottom layer, the stratum basale, which is made up of living cells that undergo mitosis, and it's there where we find the melanocytes, which secrete the pigment melanin. So we're going to continue then talking about the skin. The layer beneath the skin, which is not part of the skin, is the hypodermis. So the hypodermis is made up primarily of adipose tissue. So we can see here this kind of clusters of adipose tissue here, which is fat. And we call this, another name for the hypodermis is the subcutaneous region, or we abbreviate that as sub-Q. So in healthcare, sometimes medications need to be administered via a sub-Q injection. So you're essentially injecting that needle into the fat layer beneath the skin. And this allows for a little slower absorption of medications. Common medications that we inject sub-Q would be insulin for diabetic patients and also heparin to reduce the risk of blood clots for patients that have just had surgery or are at risk for blood clots. So we call this the sub-Q region, and some common sites that we use for subcutaneous injections would be the outer surface of the upper arm. So patients that are getting their insulin injections and have to get them administered by a nurse, the upper arm is a good choice in the back because there's usually fat in the back of the upper arm. The top of the thighs is a common, especially the inner side of the thigh is a common spot for patients to inject insulin in themselves. It's easy to access, but not easy when someone has pants on. So in the summertime, that's convenient, or if they have pajamas on, it's a little easier. But if they have jeans on, that's not a convenient location. Most people will then choose the abdomen, kind of where the muffin top would be located, just above the pants line. On the outer edges, kind of where those love handles are located, that's a good location. Otherwise, the buttocks is a possibility, but a common, not commonly used because of typically people have, younger people have more muscle there than fat over the buttocks. So the abdomen is the most common site for sub-Q injections in the hospital, or with insulin, the back of the arm. So this, again, because it is primarily fat, this is what cushions the body, the hypodermis layer, so provides cushion, insulation. So when people age, they lose fat in this hypodermis, and as a result of that, they're more subject to bumps and bruises and also heat loss. Looking at layers of the skin, we talked about some of the different strata that we see, going from the bottom, the stratum basale, and finishing at the top with the stratum corneum. There's different areas in the body that contain all 5 layers versus some that contain only 4 layers. So where we find 5 layers of these strata in the epidermis are in the palms of the hands, fingertips, and soles of the feet. So think of that, those are areas that are subject to the most friction, so they have all 5 strata within the epidermis. The rest of the body is a little bit more flexible, so therefore has fewer strata and thinner stratum corneum, so more susceptible to abrasion. For example, if some people, like my daughter, when she had foot surgery, she was walking around in her knees to try to protect her feet when she needed to go to the kitchen and get something from the refrigerator, but very quickly her knees were getting sore because those areas of the skin are not subject to friction, so they're not well suited for walking on. So our feet and hands have a greater ability to resist abrasion. And we have to think about that with our patients too. If they're leaning up on their elbows a lot, lifting themselves up in bed because of surgery on their lower part of their body, those areas are going to be subject to abrasion, and we have to really be careful with that because the skin is not suited for rubbing up against the sheets to that extent. When we look at the color of the skin is determined by pigments within the skin. Looking at melanin, remember that is produced by melanocytes in the stratum basale. And recall that the darker the skin, the more melanin is produced. It doesn't mean there's more melanocytes, it just means those melanocytes are producing more melanin. And if we look at albinism, that is an absence of melanin, so as a result the skin appears white and the eyes appears red because you're only looking at blood vessels in the retina, so that's why it looks red. But normally we see melanocytes producing brown pigment in the eyes, so if there's a high quantity of melanin being produced in the iris, in the eyes, that gives a brown color. If there's less melanin production, again, it's only a brown pigment, we see blue, and then a little more than that we see green and hazel and all the other variations of eye color. But it's a brown pigment that we see. It's just a matter of how much of that brown pigment where we see blue, green, hazel, or brown eyes. Carotene is a pigment that we see that gives the skin a yellowish color. Sometimes babies that have a diet high in those yellow-orange vegetables like the squashes can actually get a yellow pigment to their skin just from a high carotene diet. Also, for people that have a lot of blood vessels near the surface of their skin, they sometimes get a rosy cheeked appearance. And also, if you're exercising or embarrassed or there's inflammation due to infection or injury, there's more blood flow to the surface of the skin, so you're going to see, a reddish hue to the skin at the surface. And that's one of the body's way of releasing excess heat, is actually to dilate the blood vessels near the surface of the skin to allow that heat to leave the skin and into the outside air. So that's one way of controlling temperature in addition to sweating. And then also the skin will get a bluish color if the oxygen levels go down in the body. So when hemoglobin is not 100% saturated, it becomes less than 80% or more, we might see a bluish tinge to the skin, and that is because of the lower oxygen content. It doesn't mean that the blood is blue. Blood is never blue. Blood is either bright red if it's well oxygenated or dark red if it's poorly oxygenated. But that will give a bluish color to the skin as the light reflects through it. So in people that can happen, in adults that can happen pretty quickly. In children, cyanosis is a late sign of low oxygen saturation, so we really want to be careful when we start to see that in children. That's a sign that they've been low oxygen for a while. And the thickness of the stratum corneum, when people have a callus, those get more of a yellowish cast to them just because there's more layers of those dead cells. Other accessory structures we see in the skin include the hair, glands, and nails. The hair we see everywhere except for the areas listed here. Well, you can kind of just read that on your own. But hair is good for trapping heat near the surface, and also it serves in some cases, like in animals, serves a warming mechanism, especially on the surface of the head. The hair on the surface of the head helps to, again, trap temperature and keeps the top of the head warm, preventing heat loss. So babies that are born with very little hair, especially, they're not good at regulating temperature due to other mechanisms not quite kicking in yet due to their young age. But we always put a hat on newborns just to prevent that heat loss through the head. So looking at the glands here, we have oil glands and sweat glands that extend into the dermis here. So here's an oil gland. It's associated with the hair follicle. So when it secretes its oil, that oil kind of wicks up on the hair shaft to the surface and helps to moisten the skin over the surface. So we see oil glands associated with hair follicles. If we look at them under a microscope like we did in lab, you'll see oil glands kind of have this cottage cheese appearance. They're pale on the outside, dark in the center. This is characteristic of oil glands. Sweat glands have a pore at the surface of the skin, so they go directly to the surface. And when we look at them under the microscope, remember they kind of look like a jelly donut. They have a clear center with dark nuclei around the edge. And again, they secrete their contents right to the surface. So there's two types of sweat glands. There's the American glands that are used for temperature control. We find those throughout the body. And then there's the apocrine glands that are found in the armpits, the genital area, and the anal area. These are not for temperature control. And these become active at puberty, so children don't need to bathe as often as adults do because they have less apocrine sweat glands in these areas. But as we age and get near puberty, they become active, and that's where deodorants are important and showering daily is important. So we have to consider that. But then as we age, the activity of these sweat glands decrease, both sweat glands. So we find that our elderly residents in the nursing home don't need deodorant anymore because they do not sweat and those as easily as a younger person, and those apocrine glands are less active as well. However, we do pericare, which is the area around the anal and genital openings because of bacteria that, build up here because of being warm and moist, and for people that especially are incontinent, we want to make sure we're keeping those areas clean. So in the nursing home, we usually do perineal care in the morning and at night to make sure we're keeping our patients clean, but they're only going to get a full head to toe bath once a week.